I can like hello and very good evening, friends. So today we have approximately 60 minutes, and we'll discuss all the updates that are there in community medicine. So if you talk about PSM subject, if you talk about community medicine, it's slightly different from the other like subjects or disciplines where whatever knowledge you have taken, it is very important to retain that knowledge and not to study too much or too many of new topics, right? Same also applies for community medicine, but there is a slight difference that community medicine is a branch where we are dealing with a lot of current affairs, and we are dealing with a lot of changes which happen in the guidelines. So it is imperative that if your exam is just after a month or so, that whenever you're giving this exam, just before 1 month, you don't need to study what happened in 2010 or 11 or 12. You don't need to study the old things, you need to study the current affairs. So that's what makes this subject as a very dynamic subject. And that's the reason that we have this special session for you, where we are going to discuss frequently like asked topics, which are the new updates. And I'll be daring to handle a few controversies that probably like lot many of students are asking us on social media. The same questions keep on coming again and again. So I have divided my lecture strategically into three areas. So I'll just show you what all three areas we have divided into: new updates, then I will be discussing about the post exposure prophylaxis for three important diseases, that is HIV, rabies and tetanus. And third, we'll talk of few things about the maternal and child health and the demographic recent data that are there. Although all through my lectures in Marrow, we have always talked about the latest data. But of course, this is community medicine and it's a very dynamic branch and it keeps on changing. So we'll talk of new updates regarding Kayakalp, Swasthya Suraksha Yojanas, Jan Arogya, Mission Indradhanush, Anemia Mukt Bharat, lot of like questions coming on this, cancer screening guidelines, and so on and so forth. So let's begin with the first topic, that is Government of India new updates 2018 for Kayakalp. So Kayakalp was actually an old program. It was launched in points, salient points for you to remember in your exam. Kayakalp was launched on 2nd October 2014. It was related to Swachh Bharat Abhiyan. It was related to something like Swachh Bharat Abhiyan, where we wanted to have clean uh, public health facilities. So it was regarding the clean public health facilities. So under the Kayakalp, don't think that it was something else. Kayakalp, please remember, it was only regarding cleanliness and hygiene in the hospitals, in CHCs, in district hospitals. There were awards given to the hospitals on 6 monthly or annual basis, known as Kayakalp Awards. So it's a very simple program, but of course one of the most sought after things, because that is the need of the hour to improve the public health facilities. So for MCQ, as far as MCQ is concerned, remember Kayakalp is for cleanliness. That's what is the take home message. Kayakalp is for cleanliness. Next, Swasthya Suraksha Yojana. What is this Swasthya Suraksha Yojana? Students get confused. What about the Swasthya Pradhan Mantri, Prime Minister's Swasthya Suraksha Yojana? Swasthya means health. Suraksha means to protect. Yojana is a scheme. So it's a Prime Minister Health Protection Scheme. So the motive behind this Prime Minister Health Protection Scheme was not to not to have clean areas or not to promote health as such. It was to promote MCQ, it was to promote affordable and equitable health care to all sectors. That's the important line, to all sectors. What do I mean by this? That the government of India decided that because AIMS is one institute which is located in the top capital of India, that is in Delhi, so they wanted to open more AIMS like institutes. So this is what is providing affordable healthcare facilities to all parts of the country, because India is a big country. You have from Jammu Kashmir till Tamil Nadu, you have from Gujarat till Assam, Manipur. So you have too much different areas and regions. So the government of India decided to open six more AIMS like institute, six AIMS like institute. Plus now they have decided, like the National Health Policy 2017 was to open 13 more AIMS like institutes. So that's in fact a good news to all, to the medical professionals and of course to the general population. But for your MCQ exams, remember, Kayakalp is for cleanliness. Swasthya Suraksha is not for cleanliness, it is for providing affordable and equitable health to all. Next. Next is some program. We started slow, right? I started with very easy topics. So now, as we go on in the lecture, we'll keep on maybe increasing the intensity of the lecture and increasing the more technical guidelines. So, Pradhan Mantri Jan Arogya Yojana is one of the most ambitious programs launched by Government of India, PMJ. So you must have heard a lot about Pradhan Mantri Jan Arogya Yojana or Prime Minister Jan Arogya Yojana, or people call it as Ayushman Bharat. So PMJ guidelines or the Ayushman Bharat guidelines. So Ayushman Bharat was a very enthusiastic program. So I think everybody knows what is this. What is the goal? What is the target of this PMJ? The target of this PMJ is to provide to all the families, to whole country. So even WHO congratulated the health systems of India for launching this one of the massive big programs, and it has actually astonished the whole world. By the technical and administrative components of this program. It's a very beautifully built program. That is Ayushman Bharat. What is the use for your MCQ exams? What is the use for your MCQs? Remember, there is a budgetary allowance of 5 lakh rupees. There is a health coverage plan for 5 lakh rupees, and it is going to help approximately 10.74 crore families. 10.7 crore families. So many times I get question on social media whether it is 10 crore people or 50 crore people. So please remember, it is 10.74 families, which corresponds roughly to 50 crore population. So you can just remember for your exam, 5 lakh for 50 crore. That's obviously much more easy. So it's giving a 5 lakh grant to per family. It is 5 lakh grant per family given for 50 crore Indian population. So it's a very enthusiastic program. How did the government of India do it? So what is the basic plan? There is an MCQ which many students have not laid stress upon, but I would like to have an important discussion over here, that how this Ayushman Bharat was implemented. So at the basic level, at the lowest level, we have the household level. So there they will, under the Pradhan Mantri Jan Arogya Yojana, there is upgradation of health awareness and helping people to be responsible, helping, not making them responsible, helping people to be responsible for their own health. That is to have a behavioral change with communication. That is BCC, behavioral change with communication. So at the lowest level, they are trying to have the household people, we are incapacitating them. Then After the household, then the above level, which if you recall from your NRHM lectures or NUHM, if you recall, we had the sub centers or the PHCs or the urban PHCs, if you recall. So at the primary level, that is the sub centers or the PHCs, some rural PHCs, we have upgraded. Mark these words, these are important changes for your NEET exam. So we have actually upgraded our sub centers to be called as health and wellness centers. These have been upgraded to be called as HWCs, health and wellness centers. So that is a new term, health and wellness centers. So now sub centers will be upgraded to something known as health and wellness centers. And if a person gets sick, so now they can be referred to something known as first referral centers. So these are the this is the organization that is planned according as per the Ayushman Bharat Yojana, where we are giving like 5 lakh grants and 10 crore population will be taken care using this model. So what are the services the government is thinking to provide? The services which the government will be providing under the Ministry of Health and Family Welfare to all the population is all primary, secondary, and tertiary care. That's the beauty of this program, without any like charges. Primary care, secondary, and specialist care will be provided. There is no cap and no pre-existing diseases. No pre-existing diseases are taken up under this program, or family size. So anything, no cap on the money, pre-existing diseases, family size, no problem. So everything is like free treatment, everything is zero money, it is free treatment at the government or government empaneled hospitals. This is what is Ayushman Bharat program. This is what you need to remember for your exam, that we have opened something known as health and wellness centers. And at the lowest level there is health awareness. Obviously that is the main crux of this PSM thing. And after health awareness, the whole system will refer it to, after health awareness the whole system will refer to the first referral unit, where please remember, primary, secondary, and tertiary, all three areas will be catered. So remember this for Ayushman Bharat. There is a chance, if you're going to get a question on government of India national updates, it has to be on PMJ and Ayushman Bharat. I think the previous exams have already proved it for you that Ayushman Bharat is important. That I told in the classes as well. So already like students know it, that which are the important key areas which MCQ examiner might strike us. Okay. So the next mission that we are taking up is next Government of India update that we will take up is Mission Indradhanush. What is this Mission Indradhanush? Mission Indradhanush. So there is we'll at the end of the session we will have I will be answering all your questions, right? So some of you are asking about the no cap. So this is like no cap. If you take, if a person takes like uh, gets a disease, so they get like 50,000 reimbursement. They get treatment worth 50,000. That does not finish off the insurance plan. There is a limit of 5 lakh rupees. So up till 5 lakh rupees per family per year. That means there is no capping. There is no cap, that if it's not that you take it once only. The total amount is fixed under this PMJ, that is 5 lakh rupees. Okay. So next we come over to is Mission Indradhanush. Mission Indra Dhanush. What is this mission Indradhanush? So mission Indradhanush, I don't know, like many students get confused that mission Indradhanush, is it an update? Obviously, I think everybody, the whole country knows that what is this mission Indradhanush? It is a mission Indradhanush, is a mission for the immunization program, right? It is for the universal immunization program. But sometimes students have got confused that there is also known as Indradhanush Abhiyan. Indradhanush Abhiyan. Abhiyan again means mission, right? That's how sometimes these government of India programs would be. But anyways, nevertheless, to say they are all for the benefit of the general population. Mission this Indradhanush Abhiyan, just for your general knowledge, Indradhanush Abhiyan is not a Ministry of Health and Family Welfare program. It was launched by Ministry of Labor for the ESI. So they wanted to have the thought behind this Indradhanush Abhiyan was to have focus on Indradhanush. What is Indradhanush? Indradhanush is Vibgyor is seven colors. So they made that VIBGYOR. So they made the 7 day color program for the sheets in the hospital according to the 7 days, seven colors in the rainbow. So every day the hospital will be changing the bed sheets and it is going to be a clean ESI hospital. So it was in correlation with the Swasthya Mission Abhiyan, the Swachh Bharat Abhiyan, and so that is Indradhanush Abhiyan. It is different from Mission Indradhanush. Do not get confused. So let's come back to this Mission Indradhanush. A lot of questions being asked on this Mission Indradhanush. Mission Indradhanush is for universal immunization program in which we launched new vaccines. So Mission Indradhanush is for new vaccines. Which new vaccines? It is for seven vaccine preventable diseases. Which are those seven vaccine preventable diseases? Diphtheria, pertussis, tetanus. Then you have measles, poliomyelitis, and a severe form of tuberculosis. So this alongside there was a seventh vaccine which was introduced, seventh vaccine preventable diseases, hepatitis B. So these are your primary seven vaccine preventable diseases. Alongside, mark the words, alongside the government of India under Mission Indradhanush also launched some new vaccines. Which are the new vaccines which are launched under this program? So the new vaccines which are launched under this program, you count these vaccines: DPT, measles, polio, severe form of childhood TB, and hepatitis B. So these are seven vaccines. Indradhanush, seven colors. So alongside we launched new vaccines, MCQ, which are those new vaccines. This is what you need to remember. New vaccines was for prevention of meningitis and prevention of pneumonia in children, HIB, Haemophilus influenza B, HIB. So do not get confused. It is not the influenza virus. It is not a flu shot that the government of India is given. So I think previous exams have puzzled many students that was it influenza. No, it's not influenza. It is H influenza B. That is a Haemophilus influenza, which is a major cause for death in children due to meningitis or pneumonias. So it is responsible for meningitis. You must have read this in pathology, in pediatrics, and microbiology, meningitis or pneumonias. So we take care of H influenza B. So I think many of us already know it, DPT plus hepatitis B plus H influenza B. What is this total vaccine known as? DPT, hepatitis B, and H influenza B. What is this total vaccine known as? Many of us, you already must be knowing. It is known as your favorite answer, pentavalent vaccine, right? So that's how this new vaccine was included. There's a difference between my changing the colors. So all those who have listened to my lecture, I'm repeating the same lines again, but there is a difference. All those who have not attended, there is a difference between seeing this, writing these vaccines in red color, and writing these vaccines in some purple or violet color. I'll just tell you the difference. But anyways, let me just take on first and I'll come back to this color difference again. So H influenza B we have added. Next they have added is Japanese encephalitis. Japanese encephalitis is added in childhood doses. So in childhood they have given to all children less than 15 years. But recently, do you know that in August 2018 they also launched it for adults, and that is how is that is what is July August 2018, the government of India plans for adult JE vaccine in 4 endemic states, and now it has been scaled up to some more districts as well. So that was like the beauty of community medicine, that you need to study the most recent current affairs. So JE vaccine is both childhood adults. Then you have the rotavirus vaccine. Then there was addition of the pneumococcal vaccine. Pneumococcal pneumococcal conjugate vaccine. This is the rotavirus vaccine, pneumococcal conjugate vaccine, and then you have the most sought after, the injectable polio vaccine and the measles and rubella vaccine. So initially 1985, long time back, 1985, 38 years back, they launched this measles program where we had to combat measles. Then somewhere in 2006, 2007, the government of India, after 20 years of launching a measles vaccine, government of India thought, why not to open a measles elimination campaign? And under measles elimination, we made something known as keep up, catch up, and follow up campaign. So this was to combat measles on a bigger public health scale. Once that was done, recently in 2014, Government of India thought that why not to launch rubella also. Because rubella is a disease which occurs, in case it occurs in WRA, women of reproductive age group, it could lead to a lot of problems. So you have hepatitis B, Japanese encephalitis, rotavirus, pneumococcal vaccines, and MR vaccines. So these are your high risk areas where the government is thinking on public health point of view. So remember that these vaccines are important and they are newly added vaccines. Okay. So what is the age group of every vaccine? That I think everybody knows it according to the schedule, and these are the things that you need to know. This phenomena is what is known as Mission Indradhanush. So now I had told you a few moments back that remember I'm writing in different colors. The utility of these colors is it's very simple, that all the vaccines which are in red color that you see over here, these are known as the essential public health vaccines, that is publicly funded, right? So in case, listen to these words very carefully, because if you understand these words, any type of question you'll be able to solve, any type of tricky question you'll be able to solve. Mission Indradhanush is a program which is publicly funded. Publicly funded means the taxpayer will pay for this vaccine program which is launched across the country. Now, it is different from Indian Academy of Pediatrics program. IAP program is for safeguarding the health of a child, where the child is going to purchase the vaccine. But over here, the government of India is saying that we give right of health to every child. So these vaccine we will not charge. So all the vaccines, listen very carefully now, all the vaccines either in red or in purple is given by government of India. But in case of unimmunized child who was lost during the program, so children who were unimmunized, to them we will give only these 7 vaccine-preventable diseases, which are like diphtheria, pertussis, tetanus, measles, polio, TB, and Hep B. Did you get this point? So if you want to study the whole guideline on unimmunized children at this age, at the other age, 1.5 years, 1.8 years, whatever it is. So don't get confused. Just remember the essential 7 vaccines, these are the right to protection. So if a child loses any vaccine schedule, So we need to give these specific 7 vaccines. But in case you stop anywhere, remember these words also, in case a child stops anywhere, he has taken DPT vaccine or pentavalent dose 1 and he did not take dose 2 or dose 3, never restart DPT again. You always resume. That is guideline number 2. Always resume rather than restarting the vaccines. Okay, so remember these difference, that in case a child is unimmunized, we will not give hepatitis, will not give H influenza B or JE or rotavirus. We'll only give the baseline 7 vaccines. So many times students ask me one more controversy I would like to clarify over here. They ask me, sir, what is the difference between intensified mission Indradhanush and the mission Indradhanush? So intensified Mission Indradhanush is nothing very special. Intensified Mission Indradhanush is only one point, that it was launched for a short period. It was from somewhere in July, August 2017 till January 2018. It was an intensification of the mission where low performing pockets, they were being scaled up. Okay, so intensification, I don't expect a big time MCQ at your level, but just remember, I don't want to generate controversy, I just want to keep it smooth. So intensification, I think you should keep it at the back of the head. You will I think so. I'm not commenting on any big areas, but I personally think that intensified Mission Indradhanush is not a probable MCQ. Mission Indradhanush will definitely be a probable MCQ. So after learning Mission Indradhanush, let me clarify a few points about many. This is one area which I actually was behind the Marrow platform, and thanks to the Marrow team who has given me the opportunity to discuss with you the Anemia Mukt Bharat. So it is like a controversy Mukt Bharat, where like a lot of students, I don't know, daily, it's like every day I get one question on, sir, what is the final answer for iron folic acid in pregnancy in children? So there I go, and let's start with your final controversy solution. Let's try to dilute this controversy. So just look at this. Let me help you in diluting the controversy. First and foremost, I want to declare. So I know what I'm doing is a daring task. I know many students will be learning from different areas, but I have my own sources. Not my own sources. I have the Government of India sources. So whatever I'm talking is from Government of India guidelines 2017-2018. So I would like to clarify that there is a program known as NIPI. National Iron Plus Initiative. National Iron Plus Initiative. So this NIPI program was launched in 2012-2014. During that time, it was a very good program because anemia, do you know that my main problem and your main problem is not about questions, it is about the problem that the country is facing. So do you know that how many females are anemic in India? Do you know this, that roughly 98% of females are having iron deficiency anemia, no, iron deficiency status in the country? 98% are iron deficient. And do you know that out of those 98%, 50%, that is roughly from the Indian subcontinent, 50% of the females are iron deficient anemic. So anemia is a very big problem, and I think you all know about the consequences of anemia. It leads to postpartum hemorrhages, it leads to low birth weight in babies, it leads to malnutrition, IUGRs, and your whole pediatrics is there now. So the Government of India thought of launching this NIPI. NIPI is National Iron Plus Initiative, where in the first phase we gave iron folic acid. We were already giving iron folic acid to a pregnant mother. So we started iron plus. What is this plus? What you added in this? In plus, we added the children. We added 6 months till 59 months. That is 6 months till 5 years. And we also added in this age group 10 years till 15 years. 10 years, sorry. 10 years till 19 years children. we also added these adolescents. So, and 5 years till 10 years. So there were like adding of these children into this age group. But 10 year to 11 years was not a very convenient age group to handle, because the students were going to school, the students were not reporting to Anganwadis, and so many things were happening. This program was essentially, try to understand it, this program was essentially built on the foundation that we are going to give iron folic acid. Where was we were going to give iron folic acid primarily at the Anganwadis, at the Anganwadis. Okay, so this program, NIPI program, was essentially a program which was a mixture merger program between the Ministry of Health and Family Welfare and the Ministry of Human Resource Development, which takes care of the Anganwadi or the ICDS system of our country. So that was the program. So now we wanted to do something more. So now, to do something more, in 2016, the government thought of launching this Anemia Mukt Bharat, which was actually realized somewhere in 2017 only. This is known as Anemia Mukt Bharat. So they upgraded this whole thing. Now they upgraded this whole thing to a very massive scale. Just look at this scale now. So now these guidelines are old. Understand, now these NIPI guidelines are old guidelines. Now we have something new that is known as Anemia Mukt Bharat. It is a massively big program. It's a big program. So what is this program about? It is from 6 months. I'll take I'll help you in making a table now. It is from 6 months till 59 months. First age group. Second age group was from 5 years till 9 years. Third age group is from 10 years till 19 years. 10 years till 19 years, both boys and girls. Fourth age group is again 10 years till 19 years. Only girls from Anganwadi centers or from Kishori Shakti Yojana. I am writing in abbreviations. Please listen to the words also. 10 to 19 years, all boys and girls from the schools. Okay, and another fourth group is 10 to 19 years, females only, girls only from the Anganwadi centers who are not going to school, or from the Kishori Shakti Yojana, children, girls who are empaneled under the Kishori Shakti Yojana. Fifth age group. Fifth age group under this mission in Mukt Bharat, Anemia Mukt Bharat, is WRA females. It is women of reproductive age group. Who are the females of reproductive age group? Till 45 years. But we are not taking till 45, 20 till 25 years. Young females who are probably married, 20 to 25 years. From where will we take these females? From where? We'll take it from another mission that is known as Mission Parivar Vikas. Mission Parivar Vikas. So a lot of updates are already there in the my YouTube channel or in the lectures. But anyways, I'll just have a few words on this Mission Parivar Vikas separately after I discuss this anemia guidelines. So we'll take females from the Mission Parivar Vikas, which actually deals with contraceptive giving deliveries. Sixth age group after reproductive age group. Sixth age group is pregnant females, and seventh age group is last age group is about the lactating females. How much lactating? 0 till 6 months of age. So these are your big time 7 groups which have been incorporated under the Anemia Mukt Bharat. What is the target of this Anemia Mukt Bharat? The target of this Anemia Mukt Bharat is to reduce the anemia by 1/3 according to the 2015 National Family Health Survey. 1/3 anemia decline. We want to decline the prevalence of anemia by 1/3. To decline the prevalence of anemia by 1/3, you have to tackle all these 7 groups. Okay, so now what have we thought? What to give to them? So to them, we will give them something known as iron folic acid supplements. So to these group, we will give something known as iron folic acid supplements. So what MCQ number 1? What will you give to 6 months to 9 months, 6 months to 5 years of age? To 6 months to 5 years of age, we will give them, obviously you're not going to give them tablets. They are too small to take up tablets. So what do you give? You give them syrup. So you give them MCQ number 1. Mark these words very carefully. These are bi-weekly iron folic acid supplements. Iron folic acid syrup 1 ml at the dose of 1 ml. It is bi-weekly. Remember this word, it is bi-weekly 1 ml syrup form. So this is 1 ml syrup form with auto dispenser, with auto with auto dispenser. So these are the bottles that we are giving to all the children across the whole country. It is not limited only to Anganwadis. It is to all households. It is to all sub-centers, to all PHCs and to all Anganwadis. It is not limited only to Anganwadis as was the previous NIPI program. So next, in 5 years to 9 years, what are we giving? To 5 years to 9 years, we are giving them weekly iron folic acid supplements, right? In 10 years to 19 years, again weekly. 10 years to 19 years, weekly. WRA females, again weekly. To pregnant and lactating females, we are giving daily iron folic acid supplements. Are we getting this? So it makes it easy for you to remember. Remember, to children less than 5 years, bi-weekly. Everybody else is weekly. Pregnant lactating is daily. Next, what is the dose we are giving? This is where the questions come and strike me every day. What is the dose you are giving? To children who are below 10 years, the dose is 45 milligrams of iron along with 100 micrograms of folic acid. 45 milligram of iron and 100 micrograms of folic acid. This tablet is pink color tablets. These tablets are pink color tablets. To children who are 10 years to 19 years and either from the schools or from Kishori Shakti Yojana, to them we are giving 60 milligram of iron plus 500 micrograms of folic acid. 60 milligram of iron plus 500 micrograms of folic acid. This tablet is blue color tablet. 10 years till 19 years. These tablets are unmarried girls. They'll be getting these tablets 10 years till 19 years, blue colored iron folic acid supplements. The weekly iron folic acid for the WRA will again be at the rate of 60 milligram of iron plus 500 micrograms of folic acid. 60 milligram of iron plus 500 micrograms of folic acid. This tablet is red color tablet. This tablet is red color tablet, and the last daily dose is also 60 plus 500 micrograms of folic acid, 60 milligrams of iron and 500 micrograms of folic acid. This will also be red color tablet. Okay, so remember all these words. So this is what is the latest anemia mukt Bharat. This is what is the latest anemia mukt Bharat. So in this thing, age group, bi-weekly 1 ml. So all are weekly except the age group, which is the children and the pregnant lactating females. So you have different colors: pink color, blue color and red color tablets. Alongside the iron folic acid supplements, we are also giving to them, alongside iron folic acid supplements, we are also giving to them deworming tablets. So remember, deworming tablets, albendazole is the drug of choice. 12 months, same answer. I think this has not changed and everybody knows it. So I'll be very quick in this. 12 months till 5 years, we are giving albendazole. From 12 months till 24 months, child is less than 1 year, 2 years, less than 2 years, the dose is at the rate of 200 milligrams of albendazole. Okay, and in case the child is 2 years till 5 years, dose is 400 milligram albendazole. Same is given for this age group. Biannual, it is all double time, 2 times a year. This is also biannual. On the National Deworming Day, if you remember my lecture from the deworming program, we had discussed 2 times a year. We have on 10th of February and on 10th of August. So we have for 10th of February and 10th of August biannual deworming program. So you give 2 times a year. So biannual 400 milligram albendazole to all, biannual and everybody. Only to pregnant female, only to pregnant female, only to the pregnant female. Remember, mark these words. So this is also biannual. Only to pregnant female, we give single dose, one dose, or of 400 milligram albendazole, preferably in the second trimester, in the fourth month after the first month, of course, after the third month, of course. So this is what is the annual biannual program. Alongside this, we are also alongside this we are also uh, increasing the behavioral change communication. We are having more amount of like health promotion. We are having delayed cord clamping, good food, more proteins, more iron, more vitamin C, and about the infant and young child feeding program is there. So all these things are added under this anemia mukt bharat, right? So with that, what are the features of this Anemia Mukt Bharat? There are 6 features, there are 6 interventions. So, what are the 6 interventions? The first intervention is use of iron folic acid tablets. Second is to cause deworming. Third is to cause BCC, to improve the BCC. BCC is to have strong body and stable, strong, sharp mind. Strong body with stable, strong, sharp mind. Next is under the BCC is also how to have a strong body with stable, sharp mind. So they have said that the guidelines is to promote breastfeeding. Breastfeeding should be within started within 1 hour. So remember, this is also a controversial point that people say within half an hour, within 2 hours. So answer is within 1 hour. National Anemia Mukt Bharat guidelines to promote breastfeeding, to have delayed cord clamping, practice of delayed cord clamping, especially in children who are born with low weight, and to have good food to promote nutrition. The fourth intervention under this Anemia Mukt Bharat is testing for anemia. All children, all pregnant females, they are being tested for anemia. Fifth, this is again an MCQ area for you, that we are planning to have fortified nutrition. The government of India is planning to launch fortified nutrition. So there is something known as triple fortified food. What is this triple? It's a new thing. What is this triple fortified food? Triple fortified food is iron, folic acid, and vitamin B12. Iron, folic acid, and vitamin B12. It does not combine, triple fortified does not mean iodine. Double fortified food. Double fortified food. This is with iron and iodine. So there are some food products which are triple fortified. There are some food products which are double fortified, right? And sixth is, next is, last is non-nutritional causes, non-nutritional causes of anemia. So non-nutritional causes of anemia could include malaria, fluorosis, malaria, fluorosis, or hemoglobinopathies. So these comprise all your 6 interventions for the brilliantly built up program for Anemia Mukt Bharat. So remember, couple of updates on Anemia Mukt Bharat, and that is what the country is having now, Anemia Mukt Bharat, that is to prevent anemia at all the levels, right? To decrease the anemia prevalence by 1/3. So I think I have solved the controversy regarding the NIPPI program. NIPPI is an old program, National Iron Plus Initiative. It was launched by the Ministry of Health and Family Welfare with the Health Human Resource Development Ministry. But now we have Anemia Mukt Bharat, which is a big program, big time program, which is directly with central grants. It is under Ministry of Health and Family Welfare with Nutritional Ministry, with Human Resource. It's like collaborative, and with central grant. So it's a bigger program, it's a new program, it's like everything under one single roof, right? So with that, we are towards the last end of the guidelines, which I wanted to discuss is about some questions I again get about these cancer screening guidelines. So let's have a look at the cancer screening guidelines. So let me come to the cancer screening now topic. So many times student ask regarding the breast cancer, ovarian cancer, colon cancer, cervical cancer first and foremost, and oral cancers. So please remember that according to the National Cancer Survey 2018 Globocon data, Global Cancer Network, Global Cancer Network, Globocon data, it is seen that maximum people in our country are having breast cancers, followed by oral cancers and cervical cancers. So, as a part of MCQ, as a part of national screening program for general population, for everybody, as a blanket rule, we have some screening guidelines for breast cancer, for cervical cancer, and we have some screening guidelines for oral cancers. For breast cancer, the screening test of choice, the screening test is clinical breast examination. Alongside, in some cases, we are also having mammography. Mammography has higher specificity. If you have attended my classes, you would be knowing that mammography has higher specificity, but clinical breast examination, this is not, I am not saying self breast examination. Clinical breast examination has more higher sensitivity, and mammography is more towards specificity. For cervical test, for cervical cancer, the investigation of choice at the primary, mark the words, at the primary health centers. At the primary level, the cervical cancer investigations would be visual inspection using acetic acid. Visual inspection with acetic acid. I know you might be thinking about pap smear, but yes, pap smear is also there, but it is present only in specialized services where a gynecologist facility is available. At primary health center level in India, as far as Indian setting is concerned, the screening test of choice at the primary centers is visual inspection with acetic acid. It's like standard. Don't get confused with pap smears. For oral, it is oral visual So visual, oral inspection. These all have been recommended by the Government of India, Ministry of Health and Family Welfare. These all have been recommended at least within 5 years. Every 5 years, starting from age roughly 30 years till 65 years. So that's a standard guideline. 30 years till 65 years, you get yourself screened for oral cancer, cervical cancer, breast cancer. Every 5 years. That's a standard guideline. Now, going into this breast cancer. Now, moving forward into breast cancer. If you talk about breast cancer guideline. So, about the breast cancer screening for breast cancer. How to screen people, general population. I'm not talking of only females, only high risk. So, general population, the screening guidelines protocol is there. We take the female, either the female is at normal risk or the female is at high risk. What do you mean by high risk? What do you mean by high risk? By high risk people, we mean who have family history of breast cancer, who have known genetic mutations of BRCA1 or 2, who have some first or second or multiple relatives family history of breast cancer, oblique ovarian cancers. So, who have multiple family histories, multiple people suffering from this. Next is females who have heavy breast, females who are smokers, females who are smokers, early menarche, and a late menopause. Early menarche, late menopause, and nulliparity, these are all the risk factors for breast cancer. So either coming back, so either a female can be normal risk or a high risk. If this female is normal risk, then you will see whether this female is 20 to 40 years of age or this female is more than 40 years of age. If this female is 20 to 40 years of age and a normal risk female, MCQ, we say that the screening investigation or screen test of choice is clinical breast examination. It is clinical breast examination every 1 to 3 years. Of course, 1 year is not a very good answer, but ideal is 1 year every annual, but at least within 3 years. So if you get a question that the guidelines are within 1 year or 3 year, better is to mark 3 year because that is what the guidelines only say, that ideally it should be done within 1 year, but most of the females will not be able to do it 1 year. So they are recommending at least within 3 years. But under ideal situation, it should be annual. But if you get a question, I'm repeating again, I do not want to generate controversy. If you get a question 1 year or 3 year, mark 3 year because that is what is recommended by the Ministry of Health and Family Welfare. People, females who are 20 to 40 years at normal risk, we ask them for clinical breast examination, no mammography at this age. Mammography has its own disadvantages. 500 milli equivalents of millirads of exposure is there. So that is too high compared to normal X-ray where 40 to 50 milli equivalent of radiation exposure is there. So mammography is like 8 to 10 times more radiation exposure. So now, in case of normal risk, where the female is more than 40 years of age, normal risk more than 40 years of age. Now the investigation screening test of choice is clinical breast examination, which is annual. The female should get an annual clinical breast examination with mammography plus mammography. Right? So mammography, in case the female is 40 to 50 years of age, it should be done annual. In case the female is more than 50 years of age, then it should be done once in 2 years. So once per 2 years after 50 years of age, obviously because at that age the presentation of breast cancer actually decreases. in females who are high risk. High risk could be, we already did this, right? High risk could also be due to radiation to the chest. Okay, so high risk females, will classify them to high risk female. One thing is pretty sure, that to high risk females there is annual clinical breast examination standard protocol. Annual protocol is clinical breast examination annual. Next, alongside we will also do mammography. Alongside we shall also do mammography. This mammography, if the female is due to radiation high risk, if the female has taken radiation, if this female was under the high risk category because of radiation, we say that she should start at the age of 25 years. Every year, mammography annual, starting from 25 years. But if the female was under the high risk category because of some of the family history, or because of menopause, late menopause, or personal due to menopause, or because of nulliparity or any of that sort, so in these females it is recommended to start mammography annually after 35 years of age. This is the National Comprehensive Cancer Network guidelines for breast cancer. This is known as the National Comprehensive Cancer Network Guidelines 2016 for breast cancer by ICMR, Indian Council of Medical Research. So these are the guidelines that we have for general public. It is not for obs and gynae, it is not by FOGC people. So it is by the National Comprehensive Cancer Network, Government of India, Ministry of Health and Family Welfare, ICMR guidelines for breast cancer screening. And in case of cervical cancer, we have already talked that in case of CA cervix, the investigation of choice for CA cervix, the investigation of choice is visual inspection with 5% acetic acid. Visual inspection with 5% acetic acid. So this VIA, or it could be with M also. There is a process known as VIA-M, that is with magnification. So you can either do VIA or VIA-M. So in case the lesion on visual inspection is found to be white, it is like more different color, it is suspicious for cancer. So now we refer this female to the higher center, to the secondary care center, like CHCs, like district hospitals. We send them to these areas, and there they will undergo colposcopy plus biopsy for the tissue, or pap smear plus minus pap smear to confirm the diagnosis, and then we move forward, because the chances of detecting CIN, cancer in situ, carcinoma in situ, is very high with these things, with biopsy and pap smears. So you get to know that, and if you diagnose them early, obviously you're going to change the survival and length of the patient. So these are your cancer guidelines for the general population. Okay. So next we come very important and very quickly. I think we are almost off the time. So we'll take up very quickly the HIV updates. HIV updates. Recently, NACO has started with the HIV update. HIV update NACO 2018. So HIV update NACO 2018 is first thing I would like to tell everyone is about the first line ART. So ART, please remember, a lot of queries coming on this. uh, can I have the student questions? ART, if you see, ART, the first line ART, please remember the first line ART is standard. It is TDF plus 3TC plus FA variance. So TDF plus 3TC plus FA variance, first line. Second line, so in some cases, so I think we have got some requests from students. Yeah, MRI. Yeah, yes. In this cases, in people who are high risk. I'll just pause over here because that's what many students were sending uh, this question. That in breast cancer guidelines, yes, MRI is definitely there. This MRI, the guidelines say MRI is to be done as an adjunct. It is the adjunct to the screening system. So MRI is definitely there only in the high risk. In normal risk, there is no role of these things. Next, I'm shifting back to the HIV update that we were doing. So in HIV update, the first line drugs are tenofovir plus lamivudine plus efavirenz. So that's a standard treatment for HIV. That's the standard line of drug for HIV. In certain cases for renal diseases, in certain cases for people living with HIV, in case of renal disease, please remember tenofovir is not given. In those cases, the tenofovir is substituted and it is we are giving abacavir along with 3TC plus efavirenz. Abacavir with 3TC, that is lamivudine and efavirenz. All these are for HIV-1. In case the patient has HIV-2 infection, which is not frequently present in India, or in cases they have a mixed HIV-1 oblique HIV-2 infection, in those cases HIV-1 or 2, so primarily like 2. So in those cases, the drug of choice, instead of efavirenz, we substitute tenofovir plus 3TC plus, instead of efavirenz, we will give lopinavir plus ritonavir. Efavirenz is substituted. Efavirenz is substituted and instead of that we give this. So point to remember, please remember the standard guideline. I'll help you in remembering. Can you just remember 3 rules? That's how I have remembered. Just the 3 rules to remember. Rule number 1: tenofovir is not given. It is not given. Contraindicated in renal diseases. First thing. Second, rule number 2. Please remember, in children age less than 3 years, the drug of choice becomes lopinavir and ritonavir combination, FDCs. Third point, third rule, only 3 rules I want you to remember. In case of anemia, we substitute zidovudine oblique tenofovir oblique any drug with abacavir. So in case of anemia, we give abacavir. Okay. So remember, in case of anemia, zidovudine AZT is not given. AZT zidovudine is not given. In less than 3 years, tenofovir is never given. Renal disease, tenofovir is never given, not given. Okay, remember these 3 rules. So remember, the first line ART is standard, that is 3TC, tenofovir plus lamivudine plus efavirenz. Now, in case of next MCQ, in case of children living with HIV. So children with HIV. Children with HIV can be categorized into three groups: less than 3 years, 3 years to 10 years, and more than 10 years. Less than 3 years, 3 years to 10 years, and more than 10 years. In case, mark the words, in case the child is less than 3 years. You remember, less than 3 years, what is the drug of choice? We will give lopinavir. You remember the rule? It was lopinavir and ritonavir. So in case the child is less than 3 years, the child could be having less than 9 grams of hemoglobin, HB, less than 9 grams, or it is more than 9 grams of hemoglobin. Now, in case it is less than 9 grams, so in case the child is having hemoglobin less than 9 grams, you remember that the drug of choice would be abacavir plus lamivudine plus lopinavir and ritonavir. So that is what we had done because this child is anemic. In case this child is non-anemic, he is normal. So in case this child is having more than 9 gram per deciliter of hemoglobin, in those cases we will give the standard, that is zidovudine plus 3TC plus lopinavir and ritonavir combination. In case you're talking of a child who is 3 years to 10 years, again you will see, in this case again you will see whether the child is hemoglobin less than, or we'll talk over here more than 9, or it is less than 9 grams per deciliter. If it is more than 9 grams, 3 to 10 years of age, again the same answer, the drug of choice would be zidovudine plus lamivudine plus, now more than 3 years, now we will not give lopinavir and ritonavir, we will give them efavirenz. If the hemoglobin is less than 9, now do you remember our rule? Rule was never to give zidovudine, to substitute it with abacavir. So you give them abacavir plus lamivudine plus efavirenz. Now in case this child is more than 10 years, or this child is more than 10 years, 3 years to 10 years, or less than 3 years. In case the child is more than 10 years, now you will see whether he is less than 30 kgs or he is more than 30 kgs. If the child is more than 30 kgs, that is he is weighing more. If the child is more than 30 kgs, then you just see his renal status. Renal function is not okay, or renal function is okay. If the renal function is okay, you check for the creatinine level. If the renal function is okay, we'll give them the standard tenofovir plus lamivudine plus efavirenz. So they get the standard regime, the first line drug. In either case, where the child is less than 30 kgs, or if the renal function is not okay, in either case we will shift this child to this guideline. We have to shift this child to this guideline. So this forms your guideline for children living with HIV. So children living with HIV, you classify them based on their blood you classify them based on their age and based on their hemoglobin levels, less than 9 or more than 9. Rules for your MCQ exam, just rules for your MCQ exam is tenofovir never given in renal disease, less than 3 years lopinavir ritonavir, anemia give abacavir, right? So many times students also ask about PEP, post exposure guideline, during needle stick. In case of needle stick injury, many of you are already asking me questions. In case of needle stick injury, the post exposure prophylaxis for needle stick injury is now changed to standard 2 drug regime. That is tenofovir plus lamivudine. Tenofovir at the rate of 300, lamivudine at the rate of 300 milligrams. We give only standard two drug regime. So this two drug regime is given as one tablet OD given for 28 days. One tablet OD given standard for 28 days is what is the post exposure prophylaxis guideline. In certain cases where tenofovir is not to be given or it is contraindicated or the patient has a renal disease, in those cases we have a second line post exposure prophylaxis, lopinavir alongside ritonavir. Lopinavir at the dose of 200 milligram, ritonavir at the rate of 50 milligram, and this is given as 2 times BD for again 28 days. So these are given as 2 tablets morning evening BD dose 4 weeks or 28 days, right? So remember this post exposure prophylaxis in case of this is post exposure prophylaxis guideline. So in case of prevention of parent to child transmission guidelines, in case of prevention of parent to child transmission guidelines, that is to a newborn child, what is the drug of choice? We give nevirapine. Nevirapine is given as standard for all children till 6 weeks. Right? Nevirapine is given to all children standard for 6 weeks. It is extended till 12 weeks. Extended till 12 weeks. In case the mother is not taking ART or she had taken less ART for less than 4 weeks. In case of ART is insufficient and the child is breastfeeding. So if the child is breastfeeding, you extend till 12 weeks. Otherwise, it is standard as 6 weeks. Nevirapine for 6 weeks. In case of mother has already taken nevirapine, so previously nevirapine given, in case the nevirapine was given to the mother previously, now the drug of choice is not nevirapine to the child, we give them zidovudine or AZT. We give them zidovudine or AZT. So remember, the drug of choice for parent to child transmission guidelines is nevirapine standard. It is standard as nevirapine. And in case the previously was given, it is AZT. Right? So this is what we have, and for the HIV update that I wanted to share. With lopinavir, yes, we give 3 TC. Yeah. Okay, so next is second point. Very fast, we need to do it. Just 7 minutes more. Just 5 minutes to 7 minutes more. Rabies guideline. Updates on rabies guideline. What about the rabies? So a lot of students are asking these updates on rabies guideline. So rabies, remember, rabies is, I'll simplify the rabies guideline. So the post exposure prophylaxis. Post exposure prophylaxis for rabies. Post exposure prophylaxis for rabies is 0, 3, 7, 14, 28. These are the number of days. I think you can remember the number of days. 0, 3, 7, 14, 28. I'm simplifying it for you. So 90 days was there, it is not there anymore. No more 90 days. So post exposure guidelines for rabies is you take on 0 day, 3rd day, 7 day, 14 day, 28. There are many regimes. Regime number 1. Regime number 1. So this regime number 1 is something known as Institut de Pasteur Institute regime. So there is a Pasteur Institute which has given, this is the update. This is the update from 2018 WHO. This is the update. Pasteur regime is a new regime which has come up and approved by the WHO for rabies post exposure prophylaxis. So this we are giving two injections and two injections on day 0, on day 3, and day 7 for post exposure after the dog bite or any animal bite. Nothing on day 14, nothing on day 28. So this phenomena is known as a 2-2-2. So within how much time are you finished this rabies vaccine? Can you believe that it is within the 037, within 1 week? This is known as 1 week schedule, and you finish it very fast. This is all our intradermal vaccines. Intradermal two-site vaccines. These are intradermal two-site vaccine. Next schedule. This is what you already know, the Thai Red Cross. You already know this. There is no update in this. It is the previous thing only, Thai Red Cross. What was the Thai Red Cross? 2, 2, 2, 0 and 2. So this is the Thai Red Cross. It is also intradermal. These are the two new schedules which the WHO has recommended for post-exposure guidelines. Under the NRHM guidelines, we are using this. Government of India is using Thai Red Cross, but you can be expecting a question that which is the updated WHO regime. Updated WHO regime is within 1 week, 0, 3 and 7. Otherwise, in Government of India, we're taking Thai Red Cross regime, that is known as 2-2-2, 0 and 2. So how many doses you can see? You can see 8 doses. 8 doses and intradermal 1 month schedule. Otherwise, you have your favorite answers, that is the Ascend schedule, and you have the Zareb schedule. Ascend schedule and the Zagreb schedule. So what is this Ascend schedule? Ascend schedule is giving intramuscular injection of 1, 1, 1, 0 and 1, right? So this is like 1, 1, 1 and not 0 over here. It is 1, 1, 1 and 0. So this is 4 sites, intramuscular injections, 4 doses. So this is SN is completed within 2 weeks, and Zagreb is what is 2 dose, 0 dose, 1 dose, 0 dose and 1 dose intramuscular. Don't worry about SN and Zagreb, these are not to be asked, but please remember the Thai Red Cross and the Pasteur updates. That is what I wanted to say about the rabies update. So the rabies, you have a new schedule, that is the Pasteur Institute schedule, and that is about the rabies update. I would also like to clarify controversies on rabies. I know you might get confused on so many controversies, but I want to clarify over here that in case of repeat exposure, many times students ask us about the repeat exposure. In case a person takes all the vaccine, you get a dog bite and you get exposure again. So in those cases, if the previous vaccine, if the complete previous vaccine was within 3 months, then nothing has to be done. But if it is more than 3 months, now you need to repeat vaccine. Now you need to repeat the vaccine. So that is repeat dose we have for less than 3 months or more than 3 months. Please remember the rabies immunoglobulin, RIG. It is not to be repeated. It is not to be repeated within 1 year. Rabies immunoglobulin not to be repeated within 1 year. And there is no contraindication for malaria treatment, pregnancy, HIV. No contraindication. So in case of pregnancy, in case of HIV, in case of malaria treatment, chloroquine, no contraindication. You can safely, rabies vaccine is to be given. Many students are asking about this thing. Many students are asking about the pre-exposure. Yeah, about the pre-exposure, it is same. You don't have to worry about pre-exposure. Pre-exposure guideline is same. It has not changed. It is two-site schedule on 0 day and 7 day. So it's just on today and next week on same day. So today, if it is Friday, today we'll get a vaccine, another vaccine will take on next Friday. So it is on pre side. There is a small thing that many times students ask me, that's a pre-exposure guideline. Pre-exposure, before exposure you took this vaccine, it is valid for how much time? Array, it is very simple answer. It is no, there is nothing known as there is nothing known as this validity. You have to check for the vaccine neutralizing antibody, just like you do in, just the same way that you do in hepatitis B. You don't give hepatitis B vaccines again and again. You check for the hepatitis B antibodies. So over here also we will do the VNA testing, vaccine neutralizing antibody testing. If this vaccine antibody is less than 0.5 milli international units per ml, if it is less than 5 less than zero point 0.5 international units per ml, in that case give the repeat vaccine, repeat pre exposure. But usually it does not happen less than 5. It the standard is for like 5 to 7 years it will keep on staying. So don't worry about when to repeat the pre exposure. I do not think personally this will be an MCQ. Just remember, pre exposure is 0 to 7 days. When you repeat is based on the neutralizing antibody. Okay, so we have done rabies. Post exposure repeating, I don't think would be possible. We are very short of time, and the last topic I would like to take up is tetanus. Lot of questions coming on tetanus, about tetanus post exposure guidelines. Yeah, park is like, these are the updated WHO regime, boss. These are all the updated regime. So park is 3 dose. They might have given the 3 dose rabies vaccine, but these are all updates in textbook of park. So let's come to tetanus. So tetanus, you all know, tetanospasmin is the dreaded toxin. We are scared of what? We are scared of tetanospasmin. It's like a very scary toxin. So you're scared of tetanospasmin. It is the most potent toxin that we have seen. I'll come back to all the queries, I think, later on, because it just diverts us from the topic. So tetanospasmin is one of the most dreaded toxins that we have. So how to give the tetanus immunizations? So that's this guideline that we have. It's no update. There is no change in this. This is previous update, just because so many students asking me every day. So tetanus is can be of two types. Wound can be of two types. It could be a clean wound or a contaminated, or we say other wounds. We don't say contaminated, we say a clean wound or a other wound. Okay, so now you just see, you just simply ask them, if it is a clean wound or other wound, you simply ask them that were you vaccinated or were you not vaccinated. In case the patient says I am unknown about my vaccine status, or in case he has taken incomplete vaccine. What do you mean by incomplete? Less than 3 doses of tetanus during previous time. So in case they are unknown or incomplete vaccine, you simply close your eyes, give them Tdap or give them TD. So we usually do not give tetanus alone. We give tetanus diphtheria to all children, Tdap or TD or TT, whatever the protocol is. So this is, we need to give them immunization for TT. Nothing about tetanus immunoglobulin. Nothing about tetanus immunoglobulin. In case of, I have taken, you ask me, I have a clean wound, I have taken tetanus vaccine. So in case I have taken 3 or more complete vaccines, in case the patient has taken a complete schedule during his early childhood, then we ask them whether it was less than 10 years or more than 10 years ago. Less than 10 years or more than 10 years. If it was less than 10 years, then you do nothing. Then don't do anything. The child has already, the patient has already taken a vaccine, complete vaccine within 10 years. So remember, for clean wound, MCQ, remember for clean wound, 10 years is the guideline. Remember for clean wound, remember it is 10 years guideline. In case the child has taken more than 10 years, now you give them Tdap. Now you give them Tdap. Tdap is tetanus, diphtheria, and acellular pertussis. In case it is other wound, in case it is other wound with the contamination or whatever, again you ask them, did you have unknown vaccination? Do you know about your vaccination? Or in case they have less than 3 doses, incomplete vaccination. In those cases, you simply close your eyes, with contaminated wound with along with unknown dose, you simply give them Tdap plus tetanus immunoglobulin. You give them Tdap plus tetanus immunoglobulin, right? And in case the patient has taken more than 3 doses, in case the patient has taken more than 3 doses, now you check if they have taken complete schedule. Now you check for 5 years, if it is less than 5 years or more than 5 years. If it is less than 5 years, then you don't do anything. Patient has already taken. That is what is the take home message from tetanus vaccine I wanted to share, that in case of contaminated wound, the timeline is 5 years. In case of more than 5 years, you give them Tdap. So please remember that tetanus immunoglobulin was only given to unknown or less than 3 dose immunization. Okay, so that is tetanus vaccine 3 doses, which was given as a part of the national immunization schedule. That is, full DPT was given, yes or no. So with that, we close the tetanus guideline also. And last topic to take up is all the MCH indicators or the recent data. So recent data, if you have copy and pen, just write it down. It will be easy for you. The crude birth rate of our country is 20.6. The crude death rate of our country is 6.7. The infant mortality rate of our country is 34 per thousand live births. The maternal mortality rate is 130 per lakh live births. 130 per lakh live births. The neonatal mortality rate is 26 per thousand live births, and the stillbirth rate is 22 per thousand live births. Okay, the targets of the program is the targets of the NRHM or the RMNCH program is, we want to bring it down. The target is, we want to bring down the infant mortality rate to less than 25 per thousand, MMR to be brought less than 100 per thousand, per lakh 100,000. Neonatal and stillbirth rate, they should be less than 10 per thousand live births. Under the INAP program, India Newborn Action Plan. India Newborn Action Plan, that is, neonatal mortalities and stillbirth rates to be less than 10 under the INAP program. So IMR, MMR, NNMR is all this. The sex ratios, the sex ratios, you already know, it's not changed. It will remain same for next couple of years. The sex ratio of our country is 940, and the child sex ratio of our country is 914. Please remember, the child sex ratio maximum is in Arunachal Pradesh, whereas the sex ratio maximum is in Kerala. Maximum sex ratio is for Kerala, and the child sex ratio maximum is Arunachal Pradesh. So IMR, the TFR, total fertility rate of our country is 2.2. We wanted to bring it down to 2.1. So with those things, I think we have covered almost every aspect. And one more thing is about the World Health Day. The World Health Day. So the World Health Day theme of this year was universal health access. Universal health access, health for all, right? So this is the World Health Day theme that is there for this thing, World TB Day. The theme is very special for year 2019. The theme is like, it's a funny theme. It's like, it's time. That's all. It's time to stop TB. That's what this wanted to say. So the theme is like, it's time for World TB Day. Okay. So so that's it. A couple of few updates, and obviously from questions from epidemiology, nothing changes, right? Epidemiology, you know everything about case control, cohort studies. You know everything about randomized clinical trials. They will always come. Immunization, we have already discussed. Couple of things. Recent programs, we have spent 1.5 2 hours over here for discussing the immunizations and the government of India updates. And WHO theme is World Health Day theme, right? 2019 is not yet there. It will come somewhere in January. So don't worry about 2019 update right now. Theme right now. It will come somewhere in December, January. It usually comes. So this is the Universal Health Access theme for 2018, right? So with that updates, I have triggered your update section, and we have covered what I wanted to say. Now, just TB, lot of questions on TB. Mission Parivar Vikas. Mission Parivar Vikas, I just wanted to share with you some more thing. These are the logos. So you can see on your screen the logo for Anemia Mukt Bharat. You can see the logo for Anemia Mukt Bharat. Anemia Mukt Bharat. Next, this is a logo for National Poshan Mission. National Poshan Mission. So this is National Poshan Mission. It is related to nutrition. So along with Anemia Mukt Bharat and nutrition, they combined and they gave this new form to this Anemia Mukt Bharat. And last is this logo. This logo is Pradhan Mantri or Prime Minister Jan Arogya Yojana or Ayushman Bharat. Right? Just have a look at these logos. So you have this Ayushman Bharat, where you have the petals of the lotus and the flowers coming out, and Ayushman Bharat. This is your Globocon 2018 summary. Globocon 2018 summary. So you can see that, just look at this area, that among the both genders, among the all genders, the breast cancer, lip oral cancer, and CA cervix cancer is one of the most threatening cancers that we have for India currently. So this is all 2018 data. Breast cancer, lip oral, and cervix cancer is what you need to remember for your exams, that these are the most common cancers, and for these cancers only we have actually done these mass screening strategies, right? About ICD, many people are asking about ICD. ICD 11 classification is there, International Classification of Diseases. So, according to the ICD 11 classification, there have been couple of changes which already have been updated on various social media platforms. There have been increase in number of chapters and so on. So I don't actually expect the ICD 11 because for guideline, because of the fact it is not in India. People are not. It takes time for training of personnels according to ICD 11, right? So ICD 11 was just launched in August 2018, and the training modules is not yet started in India. Are you getting it? So once they come in hype and people get trained on ICDs, then you will definitely get question. But anyways, the updates on ICD is already there on many of these social media groups, on Facebook groups. Updates on ICD I can also share as a special session, because ICD 11, they have changed, like couple of things are there. There are more added chapters. The chapter, they have increased the number of chapters they have increased. And second is they have changed the numeric, from Roman. Earlier they were using Roman numericals, so instead of Roman they are using Arabic numericals now. Arabic numericals have changed, but remaining ICD 11 is same, that there are three volumes, and it just goes on with the same. So I'm not very much hopeful on ICD, but anyways, the updates are always there on a lot of this things, social medias. INIPI, many people are asking about INIPI. I is intensified NIPI program. So what is this INIPI? INIPI is intensification of the NIPI. NIPI, if you recall, that was National Iron Plus Initiative. So once you have this intensification of the NIPI, it was just for a short time. We took it to an intensified mission. So that's all. Intensification is like almost it's a mission mode. For example, you guys are studying for your PG entrance, right? So today you were sent a link that today we'll have discussion with somebody from community medicine. Some person will come and speak about community medicine. He'll confuse you with so many new controversies. So many of you must have got confused and a lot of questions are coming. So you intensified your mission, right? So today you have been intensified with a lot of new things. That's how I feel. Sometimes I feel pretty bad on myself only, that I'm training you for so many new updates, or these things about controversial matters, that there are so many so many updates. But that's how this community medicine subject is. So that is what is intensification is only for a particular set of time, right? So with that, I think a lot of questions have been already answered for your right. So Ujjwala scheme is for safer fuels, right? Ujjwala scheme is for safer fuels. Red color tablets of the anemia booked Bharat. It is same composition for children syrup. It is same composition for children syrup. For syrup, many students are asking this again and again. So for syrup about anemia booked Bharat, syrup will have what same composition, 20 milligram of iron with 100 microgram of folic acid, right? So 20 milligram of iron, 20 milligram of iron with 400 micrograms of folic acid. Okay. So that is for this thing. And weekly, 5 years, 45. It's just a small correction over here. It's 45 is 400, not 100. The other one was 100, right? That's a small correction. Please make a small correction. 45 and 400 micrograms of folic acid, not 100. So next is, thanks for the correction, and thanks for the update. Your red color is done. TDF in 3, no TDF below 10 years. No TDF, no tenofovir below 10 years. Tenofovir is for adults. Tenofovir in less than 3 years we don't give. And so mother taken nevirapine, we have already discussed. Mother taken nevirapine, IMID, literacy maximum, Kerala. Literacy maximum is Kerala. Don't mark Tripura. I don't know why people are asking about Tripura again and again. So yeah, I'm so sorry about the so many updates. I'm really sorry, and I'm I don't know. So Mission Parivar Vikas. So mission Parivar Vikas is pertaining to I'll just tell you about the mission Parivar Vikas. Mission Parivar Vikas is nothing very special. It is related to providing family planning to all the couples for providing contraception. It is providing contraception. So, do you know? You can write it on your screen. Do you know that so many new contraceptions are there? Do you know what is Antra? Antra. Let me see how many are available on the Facebook, on the YouTube videos. Uh, like, yeah, what is Antra? So Antra guidelines would be like Antra is for medroxyprogesterone acetate. Antra is medroxyprogesterone acetate, and there is another that is Chaya. Chaya is centchroman. So Chaya is the centchroman, Antra is the medroxyprogesterone acetate. So free contraception is given under the next is mission, mission Parivar Vikas. So centchroman is different and MPA is different. So very good answers. Thank you so much for having such a great response. And these were like this is what we have for mission Parivar Vikas, providing contraception. So these females who are newly married, we also advocate to have 400 micrograms of folic acid preconception preconception to prevent the neural tube defects, right? So with that, I'd like to take your permission to close off this session, and it was so nice interacting with you. So yeah, HIV once again. So that's like a very big. Already, a lot of HIV updates had been discussed, and it was like so many updates. I will go to what is happening is like there are so many updates, and there are so many people who are asking me on these YouTube top chats. So I'm very enthralled to have such a great response from everybody that I'm really I can't express my feelings, but you all are so good in your current affairs, and I would love to interact with you again. And that was all the time that I had, and I went far more. Now the marrow will suddenly we'll have a next session or something like this. So well, thank you so much for listening to this video, and that was the updates that you need to remember for your exams. For all the updates that I'm reading on the chat right now, I'll try to put them on some of the social medias through the Mara channel, right? Thank you so much for watching this video. All the very best. All the very best. Have a good time, and best of luck for your preparation. Study hard. This is the 30 days that you have. You hit it hard, and you hit it very hard. Hit it once and you hit it hard. That's the funda that you need to take on, right? Strike gold, strike gold. So remember these words: strike gold. You hit it so hard that as if there is nothing else in life. So this is the 30 days that God has given you. Spend these 30 days in the most wisest and the most fanatic manner that you can ever think of. That just read and read, and that's the only thing that you can do. Just because if you put in so much effort, universe, the whole system will put in efforts for you. Okay, all the very best. Have a good time. Study hard. Best of luck. Bye.